Okay, welcome everybody, and thanks for coming back for a second day. What I'm going to talk about is a very hot subject in clinical medicine today is pressure injuries in invasive and non-invasive ventilation. And before I start this lecture, I want a special thank you to all the bedside RNs and RTs that have been very instrumental in helping us improve the amount of pressure injuries that we have in this patient population, because without the bedside clinicians, we could not at all succeed. I have no real or perceived conflict of interest that relates to this presentation. Any use of brand names is not in any way to endorse the product, but merely an illustration or point of emphasis. So we're going to describe the frequency of pressure injuries during invasive and non-invasive ventilation, define the different classifications of pressure injuries, and review clinical management strategies in preventing and reducing the incidence of pressure injuries. So what is a pressure injury? According to the National Pressure Injury Organization, a pressure injury is a localized damage to the skin and or underlying soft tissue, usually over a bony prominence or related to a medical or other device. The injury can present as intact skin or an open ulcer. Depending on its level, it can be painful or not. And interestingly, some of the worst pressure injuries are not painful because nerve endings have been destroyed. So when you look at the stages of pressure injuries, you have basically 4 defined stages: an unstageable, because the wound is so severe it cannot be assessed. And then you have a deep tissue injury that can cause intact tissue to be totally destructed in a 1 to 2 day period. So I'm going to talk about these all in a little bit more detail, but this comes from the National Pressure Ulcer Advisory Panel classification system. So let's start with layers of the skin, because I think in order to talk about pressure injuries, we have to talk about layers of the skin. So when we look at the skin, it's made out of these 3 layers: the epidermis, the dermis, and the hypodermis. And then we have blood vessels that are in the hypodermis level and a little bit in the dermis. We don't have really blood vessels on the surface here. We have hair follicles that kind of sit in the dermis, hypodermis, sweat glands, fat, and convective tissue. Now, when we talk about these injuries, the depth of these injuries and the stages are going to be determined by what layers are injured and the function of the tissue, the ability to repair the injury to the tissue, or the sensation to the patient. Okay, so for example, if you have a deep tissue injury and you injure and destroy the blood vessels and a lot of the nerves down in this area, you're not going to have any pain, because there's no pain to have, because the nerve endings have been they've been basically totally devastated. But if you have injuries up in this area, they can be quite painful because the nerve endings are still intact. So keep that in mind. So the first one, we'll start off with stage 1. A stage 1 is lightly pigmented. Okay, it affects the epidermis and slightly the dermis. There's some changes in sensation. It can be painful, and it also can be warm to touch. But there's really no loss of fluid or skin at this level. And you can see again at the different levels, hair follicles aren't destroyed, vessels aren't destroyed, and you haven't got into the bone, the muscle, or the deep fatty tissue. Now you go to a stage 2, which affects the dermis, and this is often considered to be one of the most painful type of ulcers, in a sense, because it's deep enough to cause a substantial amount of tissue damage, but it's not deep enough to cause injury to the nerves. So there's a partial thickness skin loss, and often there's a shallow crater at this point. This is, again, you're into you're deep beyond the epidermis, and you're into a pretty good section of the dermis. You're not really in the hypodermis yet, And again, this is what it looks like. And when you look at this, I mean, we've had brush burns and things like this, and we know this would be quite painful. All right, this would hurt. All right, especially if you got water in it, or if someone pressed it or something like that, or someone rolls you on it, it's gonna be painful. So when we look at a stage 3, okay, there is now epibola. Okay, epibola means that there is actually necrotic areas of tissue, and it can be very painful too. And there's now loss of tissue where it affects the subcutaneous tissue. And some call this a full thickness skin loss because there's actually necrosis of the skin, which means that this skin that is gone is not going to grow back on its own. It's dead tissue. So at this point, these individuals probably going to need some form of skin grafting in order to close up that wound. It's not going to necessarily close up on its own. And you can see you're almost down now into the nerves, into the muscles. And this again is very, very painful. And you look at this wound right here, and you can just take a look at it, and you can say, holy shit, that looks like that would really hurt. All right. And when you kind of get to this point, you have this full thickness skin loss with extensive necrosis to tissue, bone, or skin. And you can see bone here, and you're all the way down. So this is not going to heal on its own. This is going to have major medical interventions. All right. And you're going to have to try to figure out, how you're going to, 1, heal this, and 2, how you're going to graft this and take care of this. A wound like this may take anywhere from 8 months to a year to heal, if it heals at all. All right. This is extremely, now these aren't quite as painful because a lot of the nerve endings have been injured, and you can get a osteomyelitis, and you can get inflammation of the bone from these. And these are unstageable, meaning that there is so much death of the tissue, and there's a dark eschar that there's no way of really figuring out what's underneath this. All right, because you have all this dead tissue, and you really can't figure out what's beyond this dead tissue. This is someone's heel of their foot. All right, and you don't really know how deep this tissue is and what the extent of the injury is, because you got to get rid of this dead tissue in order to really assess the depth of this tissue. But it ain't good, I'll tell you that. And the depth often is all the way down to the bone, unfortunately. And then you can get what's known as a deep tissue injury. Within 24 to 48 hours from these type of injuries, you have total destruction of the tissue. The tissue is totally dead. And again, skin grafting, but this is tissue that is non-viable. It needs to be surgically removed because it's dead tissue. It's very highly, leads to infection, and can cause a plethora of other problems like septicemia, and sepsis and multi-system organ failure. So those are kind of the classification of the deep tissue injuries. And again, when we look at them caused by some of the devices we use and some of the interventions we use, keep in mind, what type of injury are we causing, and what is that going to do to mortality and morbidity of the patient. So the magnitude of this problem is pretty unbelievable. So pressure injuries rates vary considerably by clinical setting, anywhere from 0.4 to 38% in acute care, from 2.2 to 24% in long-term, and from 0 to 17% in home care. So, I mean, if you're in a ICU, 1 out of 3 patients could get pressure injuries. If you're in a nursing home, 1 out of 4 will get it. And at home, even almost 1 out of 5. Hospital-acquired pressure injuries result in significant patient harm, including pain, expensive treatment, increased length of institutional stay, and in some patients, premature mortality. Okay, and obviously, and a thing we can't, forget about is that these things are very, very painful, and they're very expensive to treat. So trying to prevent them is very prudent, because being proactive is very, very important. It's estimated that approximately 2.5 million patients in the United States in acute care facilities suffer from pressure injuries, and 60,000 die from those complications. The cost of treating a single full thickness pressure injury can be as high as $70,000. So if you have a big hospital and you have a lot of patients, and a third of them get pressure injuries, your institution is paying an awful lot of money in order to basically take care of iatrogenically induced injuries. And a lot of these costs are not covered by insurance or by Medicare, because they're considered to be a patient, an institutional error. All right. And $11 billion annually is the cost. So when I did asthma yesterday, the cost was like 22 billion. So you understand why healthcare costs so much, because just looking at two different entities here, we're at $32 billion. Okay, wonder why the deficit is at trillions. Now, we do know that if you become proactive and you really work hard to reduce pressure injuries, it can have substantial benefit for patients and also for the institution. In 2011, 2014, 14 hospitals worked to prevent and reduce pressure injuries. And they were able to reduce pressure injuries by 40%, and they were able to prevent over 4,000 pressure injuries, which saved, well close to $2 billion. So again, I think it's important to understand that these things are very, very harmful, not only to the patient, but to the families that have to see it, and also to the healthcare workers who have to treat it, and as the institution who have to pay for it. So there's a magnitude of problems. So there's a physical cause of pressure injury: skin mutilation, pain, impairment of mobility, prolonged hospital duration, and depression and anxiety. And you got to understand, patients sometimes, they maybe be trauma, maybe somebody who has COVID, whatever, they're very sick. They only have a reference of what they knew they looked like prior to being very ill. They spend a few weeks in the ICU, and they wake up and they look in their body and they have injuries like this. Well, this is going to be extremely upsetting, and it's going to cause tremendous amount of anxiety and depression. You take a beautiful young woman, and all of a sudden now they have a huge pressure injury on their nose. This is going to change their whole, self-esteem and who they are. And again, trying to get patients out of bed who have ulcers like this on their body, it's going to be, they're not going to want to walk or move. And what happens when patients don't move? They're at a high increase of pneumonia and other type of respiratory sequelae. So, it's multi-layered, these pressure injuries, and not just a pressure injury. Now, risk factors for developing a pressure injury is advanced age, greater than 65 years old. No, I'm there already. Mobility, inadequate nutrition, hydration, neural sensor deficiency, device-related skin procedures, multiple comorbidities, diabetic, obesity, peripheral arterial disease, and circulatory abnormalities. And there's a whole gamut of patients that have a plethora of these problems. And, a lot of patients that come in the hospital are elderly, and they fit all this criteria. And unfortunately, this lends itself to a high incident and high risk for pressure injury. And these are the common areas that are prone to pressure injuries just from laying in a bed and not being turned periodically. the heel, the buttock, the elbow, the shoulder, the back. I mean, you know yourself, if you sit in a chair for a period of time, you get up, you have a big indentation on your leg or something like that if your arm was laying on it. People get up and out of bed after a good night's sleep and their face is wrinkled. So there's a lot of different pressure points, and we need to be cognitive of these pressure points, and it needs to be very stressed that patients have to be turned periodically. When we prone our patients, we have to make sure we turn the face from side to side, or they're going to get a pressure injury. We do that every 2 hours. But in the area where you're overworked, you have too much work to do and you don't have enough people, pressure injuries sometimes occur just because there isn't enough time or enough staff in order to do what we need to do and do it effectively and in a timely manner. So medical devices have been identified as an intrinsic risk factor for development of pressure injuries, with as many as 30 to 70% of medical device-related pressures and injuries result from respiratory therapy equipment. So respiratory therapy equipment historically has been notorious to cause pressure injuries. So common respiratory care devices associated with pressure injuries is endotracheal tubes, NIV masks, oximeters, oxygen devices like cannulas, pendants, and even high flow oxygen. So you look at a patient here that had a nasal cannula on, and again, the nasal cannula may be too tight or was on for a prolonged period. You understand these patients also have a gamut of physiological problems, poor perfusion net, which makes them more susceptible. But there you can see that's a pressure injury. This is a deep tissue injury from having a BiPAP mask on for a prolonged period of time. And again, how would you like to wake up and you have a COPD exacerbation? You're not sure what's been going on for the next 2-3 days. You finally start being able to breathe again. You start getting your sensorium, and you look in the mirror, and this is what your face looks like. Okay, this is going to be extremely unsettling and even tragic. And then obviously pressure injuries associated with endotracheal tubes at this point. So the question is, how can we reduce these pressure injuries? What are the steps that we can do as respiratory care practitioners to reduce pressure injuries? So it's not an easy task. I mean, I know Terry, this is how he gets up in the morning and does this before he basically goes downstairs from the bedroom. And Al, when he goes on vacation, he's always doing this with his wife. So it can be done, but it's not an easy task, to be very honest. It's very, very hard to prevent pressure injuries. So you have to be not reactive. You can't deal with pressure injuries after they occur. You have to be proactive. So let's talk about endotracheal tubes to help reduce lip injuries associated with endotracheal tubes. So the StarWise is use the most appropriate securing device and correctly secure the endotracheal tube. This is very, very important. There's a lot of different ones out there. Obviously, probably Hollister's Anchor Fast is the most commonly used these days, but that may be inappropriate for patients who have burns or patients that have certain facial contour or skin tagger. So you can't say, well, and be monolithic and say everybody that gets intubated should have a Hollister Anchor Fast on, okay? The endotracheal tube position should be changed repositioned every 4 hours, and that should be documented, and that should become standard of practice. And the securing device should be changed when indicated, like, sometimes it's, depending upon who you read and what's the manufacturer, it's anywhere from 3 days to 5 days, or when it's soiled or it doesn't fit appropriately. If all of a sudden, you put a securing device on a patient, all of a sudden they retain 20, they're 20 liters positive with fluid, well, their face has swelled, so that is very tight on their face. Okay, that's going to cause a pressure injury because the position, the strap was when the patient was not fluid overloaded, it is not going to be appropriate for when they're now fluid overloaded. So you have to take that in place. And again, early ventilator liberation. If you extubate patients and use spontaneous breathing trials and awake and sedation protocols, you can get patients off ventilators. So you can't get an endotracheal tube pressure injury if you liberate patients early as you can and appropriate. So now these are 4 things that, we do at our institution. Those that have worked at our institution, and, there's a few people, I see their names, they're very aware of this, and they understand this is our standard of practice. Again, there's a lot of different type of endotracheal tube holders out there. I don't profess one is better than the other. What I do profess is that you should use the most appropriate one for the most appropriate patients. Like, some may be better at securing the tube for short periods of time. Others may be better at minimize pressure injuries for long periods of time. You have to weigh, the benefit and, risk benefit of some of these holders. Obviously, you don't want an endotracheal tube dislodged because that can equal death. But at the same token, you want to try to use the one that is the most, conducive to reducing the chance of a pressure injury. So what we do when we document endotracheal tube management, we inspect and assess the endotracheal position and lip pressure. So we look at it and make sure that we don't see, evidence of edema or evidence of bruising, and rotate the endotracheal tube every 4 hours with documentation, and notify the wound team of any potential pressure injuries. I think it's important, again, if you start seeing edema, you start seeing a little bruising, is be proactive right there and see, is there something we can do to prevent that wound from progressing to the next stage, instead of just simply saying, oh, damn, he has a wound there, and just try to avoid it. Is maybe we can do something to kind of help it and heal it early on. So obviously the anchor fast most are familiar with. You can move that fairly easy. I mean, the days when we had to tape endo tubes was more difficult to move an endo tube, but with most of these fancy tube securing devices, the ability to move the tube from left to center to right is enhanced. And this is the old medical record we used to use, MetaVision, and the respiratory therapist would document every vent assessment where that endo tube was. And then, somebody like myself would check it periodically. And then if there was a pressure injury, we would definitely say, okay, what happened here? Was his tube moved or not? Sometimes pressure injuries happen, okay? And there's nothing, you can do, but you got to try to do your best. And this is now the newer medical record, and it says, again, where is it located, center of mouth, where is repositioned, where, what's it's secured at 26 and things like that. So it's important that you have good documentation and your bedside clinicians realize this is a standard of care. And every time you do a ventilator assessment, Kimmy Roth did this, and she documented this information. And again, if you can do early ventilatory liberation, daily sedation holidays when patients are stable and they have met their clinical endpoints when it comes to ventilation and oxygenation, and they are, stable, what caused them to get on the ventilator is no longer an acute process, then it's time to try to do a daily assessment for wean-in and a daily spontaneous breathing. So all our respiratory therapists every day assess the patient for, are they ready for wean-in? Do they meet the criteria for wean-in? And if they do they meet the criteria for spontaneous breathing trial? And they conduct the spontaneous breathing trial. And if they don't do these things, they need to explain why they didn't do it. Now, obviously, if I have a patient in severe COVID ARDS, they're not going to meet the criteria for wean-in because they're too clinically unstable. Or if I have a patient that has a massive intracranial hemorrhage, they're not going to meet the criteria. It's quite explanatory. But again, we don't want to say, well, I'm too busy, we don't want to wean patients, or we decide not to wean the patient because this was this is what I thought. No, we use strict systematic criteria to make sure everybody is standard on when weaning should take place. So we have things like a daily screen. Okay, what's the FiO2, SAT, how much people they are, minute ventilation, what's their heart rate, respiratory, what's their blood pressure. And if they meet all the criteria, then you go ahead and do a spontaneous breathing trial with them. And we do it anywhere from 30 minutes to 120 minutes, depending on the patient and the situation. And we notify the pulmonary fellow or the surgical fellow, and hopefully we can get the patient liberated. So that's with endotracheal tube. That's been our now I got to tell you, we did very well up until COVID. And then when we started to prone patients, and we were prone an average of 25 patients a day through the first wave, and the second wave, probably about 30 patients a day. We've had a fair amount of pressure injuries in patients who were prone greater than 7 days. But my point is that, we've tried a lot of different things to prevent pressure injuries during proning. But when you're proning patients, a week, 2 weeks, the chance of pressure injuries, not just endotracheal, but other pressure injuries, is enhanced tremendously. But, in most intubated patients, we've done very well with our pressure injuries. Now, non-invasive ventilation is another situation where, when you're using things like NIV mask and you're using a lot of BiPAP, you can get a lot of pressure injuries because masks are notorious for causing facial pressure injuries, and the face itself has a lot of bony prominences that can cause can cause pressure injuries. So a few years ago, now it seems to be very long, but it's probably about 5 years ago. We were having a huge problem with NIV pressure injuries, huge problem. I think we had, 30, 40 pressure injuries. So my boss, and I have so many bosses, came to me and said, Ken, you better fix this problem, okay, or we'll have your head on a platter. So we had to look at why do we have all these NIV. And interestingly, we have protocols for all kind of clinical management. Everybody that's worked with over here, we have protocols for nitric, we have protocols for a high flow oxygen, we have protocols when you can go to the bathroom. But the bottom line is we did not really have a systematic and consistent clinical management of NIV. We didn't really have a well-designed plan to manage your chronically refractory NIV. Like, what do you do with a patient you can't get off of NIV? And we didn't have good endpoints germane to NIV management. So the bedside clinicians often sat there with their hands tied, not really knowing what if the patient had met the endpoints and it was a patient a candidate for an NIV liberation. And believe it or not, it was amazing. Even the respiratory therapists really didn't have a good grasp on NIV application. They didn't really know how to fit masks correctly. They didn't really know how to use all the parameters correctly. And this included the providers and nurses also. So what we did was, with some countermeasures, we first looked at different NIV masks, okay? So, technology is always advancing, and we had been using the same mask for quite a while. So we got a different mask in there. We had a bunch of, people evaluate them, and we did 1 unit at a time to see what the feedback of this mask was. If I tried it in the medical surgical ICU and they said the mask sucked and this was really hard to use, there was no sense in trying it up in cardiac ICU, because why? It had been past the first group, or vice versa. We developed an interdisciplinary team to review the NIV process. This was incredibly important, because what we did was we used lean technology, and we kind of got the bedside clinicians invested in this. It wasn't a bunch of people who sit in the office saying, this is what we're going to do. We got the nurses at the bedside. We got the therapists at the bedside. We said, look, we have a problem here, Houston. How can you help us? What are your barriers to solve this problem? We enhanced RT, RN, NIV mask. We educated every nurse and respiratory therapist in the network on how to utilize the NIV mask correctly, how to size it when you take it off and you reapply it, how it should be applied. what are the skin barriers we're going to use. We developed a multidisciplinary practice guideline algorithm to NIV management, and we utilized an alternating mask strategy and evaluated enhanced skin barriers. So these were the countermeasures that we incorporated in this whole process. Now, when I formed this multidisciplinary team, so this was my team, so they came to First Man and sat there, and then I explained what our goal was going to be and what our project was, and this is what they did. This is how they reacted to me, okay? Because when I told them our goal was to almost reduce pressure injuries down to 0 NIV, the room roared and said, you know, what was I smoking today? So we focused on lean ideology, you know, define, measure, analyze, improve, and control the Six Sigma philosophy. And again, you know, we did a lot of bedside assessment, you know, utilize the people at the bedside to try to figure out what are the best countermeasures and how to measure our success. So our team had RRTs, RNs, wound team, and we had physician providers part of the team. So anybody who was involved in the NIV process, we got into the team. And we trialed a lot of different masks. We educate the RRTs. These were some of the different masks we trialed. And this was very, very important, because if you don't correct and get the correct size mask, the mask is going to be moving all over the place, and it's going to cause a tremendous amount of friction, or the compliance is not going to be very high for the patient. It's going to be too tight, it's going to be too loose, it's going to be too big. And it was very important that when you measure these masks and figure and size them, that you size them with the patient's mouth open a little bit, because most individuals don't just sit there with their mouth closed. Their mouth should be partially open, and then that's how you measured it. And we also stressed that a leak is okay on non-invasive ventilation. Okay, you don't want a lot of unintentional leaks, meaning that all the air is coming out, but you know, you can have anywhere from a 10 to 30% leak and still effectively ventilate the patient. Because if it's less than 10%, it's probably going to be too tight a patient, and it's not going to be effective, and it could cause a lot of air to go into the abdomen versus into the lung. So again, you know, just like when clinicians do handbag resuscitation with a resuscitation bag and a mask, you know, they think they have to cement the mask on the patient's face, but NIV masks, just like resuscitation masks, are cushioned real nice, and they should sit on the face, not be cemented to the face. So that's why the education was very important. We also did this alternating mask procedure. So if patients were going to be on NIV for, you know, greater than 12 hours, we alternated the mask. We might go from a nasal oral mask to a full face mask every 4 to 6 hours to reduce the same stress points. And the bottom line was that when I first saw this, I thought, oh man, I don't know who the hell's going to want to wear that. But I found out that a lot of patients really, once they trial this mask, they would rather actually keep this mask on, and they find it more comfortable. All right, but those were the two masks we used to make sure we were doing an alternating mask strategy. We also looked at a lot of different skin barriers out there. We ended up going with what's known as projected gel, but I'm not, you know, these other ones, you know, could be just as effective. But so for our patients, you always use some kind of skin barrier underneath the mask. And if you look at this cushion of mask, the mask is to sit on the face, not to be totally pushed onto the face. All right. But yeah, we use a projected air, but so our patients get some kind of skin barrier to help protect, you know, the skin underneath it from the mask pressure. So it was important to also determine when should we think about getting patients off an IV, how do we escalate care, how do we decide that we should go to, invasive ventilation? So we needed some clarity on the clinical management of patients on NIV and not wait until a provider came to the bedside. I mean, things are really busy. I mean, we could have, the provider might end up having to see 30, 40 patients in the ICU in a given day. And an NIV patient may be last on our list, so we needed to figure out a way, how can we empower the nurse and the therapist at the bedside to be able to move the NIV process forward or backwards. So we kind of first start out with the order set. All right. So when the provider orders, they have to order a certain what patient population. They have to put in the settings, and they have to then put in an indication. And then this is very important. They have to add the specific endpoints. They have to add, what is the goal respiratory rate? What is the goal SAT, heart rate, pH, okay? And alert the physician if mental status deteriorates or no longer can maintain airway and not tolerate. Well, of course, that's going to be a yes. But the bottom line was, by making the provider fill this in, and this in, okay, and the indication, this allowed the bedside clinicians to have a very clear communication path on where our endpoint was with this patient. What was our clinical goal? And this is an example of what the order actually looks like in real time in our Epic order set. Now, also, the nursing staff was engaged in that they have to, every 4 hours or 8 hours, depending on the unit, they had to do nursing documentation, document the skin and pressure protection that was being used. So again, it takes a village in order to make sure that we reduce pressure injuries. So, our nursing colleagues are extremely important in this process, because they spend more time with the patient than the respiratory therapist does, because we come in, we do your things, we move the next patient. So nurses are very, very instrumental and valuable in this process. And, they marked exactly what they were using, like skin device, areas padded, things like that. So they again, document this information. And then we developed this NIV protocol that looks at, well, when patients are put on CPAP, what do we do? And when patients are put on BiPAP, what do we do? And also, this was important to determine if the patient was a DNI or DNR, because again, we need to have clear goals, because if patients are not doing well on NIV, well, what's our next step? Is it invasive ventilation, or is it comfort goals, comfort care for the patient? So goals of care had to be documented. But this gives you a nice, example of a algorithmic approach on how we manage patients on NIV to try to reach the clinical endpoints, and hopefully, when we get to a certain point, assess for weaning or liberation. And these are the nodes, and included in the nodes were things like, the NIV clinical practice guidelines should be activated. Clinical parameters are to be assessed with 2 hours. Providers should be notified how the patient's doing. What are the the contraindications, NIV? So we're not putting somebody on NIV who doesn't have a face, all right? Or they have upper airway esophageal surgery, things like that, or they can't protect their airway. And like here, we could see, consider liberation when CPAP is 5 and FiO2 is 40%. And then we added here, if patient on NIV for 6 hours or more, begin alternating full face mask with aero nasal mask every 4 hours. And it again, see skin integrity assessment, making sure that in this protocol, we did everything we could to optimize skin protection along with CPAP and BiPAP clinical management. This was part of our team that was very much involved with it. Okay, some of these, Jim Gates here has retired on me. Paul has retired. Laura's working at a different hospital. Some of these people are still. Jen got married and is doing something else. So some of these therapists are no longer with us, but they were all instrumental in helping us, do this process. And again, this was, so in FYI 16, we had 24 pressure injuries at the Cedar Crest campus, 8 at Muhlenberg, so 32 total. In September is when we started the intervention, in the sense that, see, we're on a bad road already. We had 5 in the first 2 months. And then this is when the intervention started, where we had finished the education, put the protocol in, used the barrier, and used the alternating mask strategy. And you can see we did very well. We only had 2 after the intervention. So for the total, we were down to 5 and 2. So the following year for our FI was fought, down. And for the next year, we only had 1 pressure injury. And really, when we had this one in January, we almost sat and cried because we were so upset because we had a pressure injury. So we went from 32 in 2 years to basically 1. So we were very, very, happy with our results and that. We haven't been able to keep the results quite this good, but we have been kind of around this 5.2, 4.1 area. But we've not got near going to this. And I must say, the respiratory therapists and nurses do an incredible job in many different ways. But one way is that a lot of times when I did BiPAP rounds, those patients were already on a cannula because they already had taken it upon themselves to get the patient liberated. Because again, you won't get a pressure injury if you don't have a mask on your face, just like endotracheal tube. So we did daily NIV rounds. I had a patient list from the EMR. We educated new staff. We could send them to seek additional countermeasures. We're looking at a new NIV mask right now made by Fisher Paykel. So I think it's very important to not sit on your laurels, but constantly look at how can I get better. And this is an example I can print out with Epic, every patient that's on NIV, and I can check out, if, we're following the standard of care. There, we empowered the bedside staff. We collaborate clinical rounds. We now know that NIV is very important to make sure that we have good defined clinical endpoints, and empowering the therapist and nurse allows those endpoints to be achieved much quicker than waiting for a provider to dictate when to liberate or when to escalate. So in conclusion, in this presentation, pressure injuries are expensive and cause a lot of suffering. And one of the things that I thought I had in here and I didn't, it doesn't only cause suffering for the patient, it causes suffering for the family and for the healthcare givers too. Seeing wounds of your loved one or taking care of wounds as a bedside clinician is extremely taxing mentally. And one thing I've learned from, COVID is that, mental distress is extremely, extremely exhausting and very suffocating to the humanality of the individual. So understand that, if my loved one, the last time I saw her, had this beautiful face, and I come in and I see these pressure injuries, this is going to not only cause tremendous, anxiety in me, it's going to cause tremendous amount of emotional distress and anger. So understand that too. Most pressure injuries are avoidable with proactive care. All conditions must be aware of potential pressure injuries, not just respiratory therapists, but tech partners, nurses, everybody else. And constant vigilance is mandatory. You cannot sit back and say, okay, we reached our goal, we can just sit back and enjoy it. No, it's a day-to-day process that everybody has to be involved with. Again, you guys know how to get a hold of me. If there's any questions, you know the process by